Hello and welcome to this comprehensive guide on shock, a critical condition characterized by decreased circulating blood volume and subsequent cellular dysfunction. In this video, we'll explore the causes, symptoms, signs, investigations, and treatment options for shock, including a detailed look at multiple organ dysfunction syndrome. We'll also address some common USMLE-style questions to help reinforce your understanding. Question 1. A 45-year-old man presents with symptoms of thirst, palpitations, and sweating after a car accident. On examination, he appears pale, has cold extremities, and a systolic blood pressure of 85 mmHg. What is the most likely diagnosis, and what is the initial treatment? Answer. The most likely diagnosis is hypovolemic shock, likely due to hemorrhage from the accident. The initial treatment involves rapid fluid resuscitation. Start by inserting the largest bore cannula, size 14 or 16, and initiate intravenous infusion with crystalloids like normal saline or Ringer's lactate. For severe hemorrhagic shock, cross-matched blood should be administered as soon as possible. Explanation. Hypovolemic shock results from significant blood loss or fluid loss, leading to reduced blood volume and inadequate tissue perfusion. Rapid fluid resuscitation helps restore blood volume and improve blood pressure. Question 2. A patient is suspected of having cardiogenic shock following a myocardial infarction. Which diagnostic tests are most appropriate to confirm the diagnosis? Answer. To confirm cardiogenic shock, perform a chest X-ray, CXR, an electrocardiogram, ECG, and an echocardiogram. These tests help evaluate heart function, identify potential causes, and assess the severity of the shock. Explanation. Cardiogenic shock is often related to cardiac dysfunction. CXR, ECG, and echocardiogram are essential for diagnosing myocardial infarction, assessing heart failure, and identifying underlying cardiac abnormalities. Question 3. A patient in shock exhibits a cloudy consciousness and confusion. What are the immediate steps to address these symptoms? Answer. Immediate steps include securing the airway, ensuring adequate breathing, and restoring circulation. Administer oxygen via nasal prongs or facial mask, and initiate rapid fluid resuscitation. Monitor vital signs closely and address any underlying causes of the altered consciousness. Explanation. Altered consciousness in shock can indicate inadequate perfusion to the brain. Immediate intervention to restore oxygen and blood flow is critical to prevent further neurological damage. Question 4. A patient with shock exhibits cold extremities and collapsed peripheral veins. What is the most appropriate method to administer fluids rapidly? Answer. The most appropriate method is to insert large-bore intravenous cannulae, size 14 or 16, into the largest visible veins. Use a high-flow infusion system to rapidly administer crystalloids such as normal saline or Ringer's lactate. Explanation. Large-bore cannulae allow for rapid fluid administration, which is essential in managing hypovolemic shock. High-flow infusion systems help quickly restore blood volume. Question 5. In a case of septic shock, what investigations are crucial to perform, and why? Answer. Perform a septic screen to identify potential sources of infection, including blood cultures, urinalysis, and imaging studies. Additionally, check a full blood count, FBC, blood urea and electrolytes, BU, creatinine, and liver function tests, LFT, to assess organ function and detect any metabolic abnormalities. Explanation. A septic screen helps identify the infection-causing septic shock, while additional tests assess overall organ function and guide appropriate treatment. Question 6. For a patient with hypovolemic shock, what is the recommended infusion rate of Ringer's lactate for an adult? Answer. The recommended infusion rate of Ringer's lactate for adults is 70 ml per kilogram of body weight. Monitor blood pressure, urine output, and clinical response to adjust the infusion rate as needed. Explanation. Ringer's lactate is used to restore blood volume and maintain electrolyte balance. The infusion rate is based on body weight and adjusted according to the patient's response. Question 7. A patient with shock has an elevated blood glucose level. What is a potential metabolic complication that might arise, and how should it be managed? Answer. A potential metabolic complication is hyperglycemia, which can occur due to stress-induced insulin resistance. Management includes monitoring blood glucose levels and administering insulin if necessary to control hyperglycemia. Explanation. Stress and shock can disrupt glucose metabolism, leading to hyperglycemia. Monitoring and managing blood glucose levels are essential to prevent further complications. Question 8. A patient with shock develops acute respiratory distress syndrome, ARDS. What are the key management strategies for ARDS? Answer. Key management strategies for ARDS include providing supportive care with mechanical ventilation if necessary, maintaining adequate oxygenation and ventilation, and addressing the underlying cause of ARDS. Explanation. ARDS involves severe lung inflammation and impaired gas exchange. Mechanical ventilation and supportive care are crucial for managing this condition. Question 9. In the case of multiple organ dysfunction syndrome, MODS, resulting from shock, which organ systems are typically affected? Answer. MODS can affect various organ systems, including the central nervous system, encephalopathy, cardiovascular system, tachyarrhythmias, pulmonary system, acute respiratory failure, renal system, acute tubular necrosis, gastrointestinal system, ileus, pancreatitis, liver, ischemic hepatitis, blood, disseminated intravascular coagulation, metabolic system, hyperglycemia, hypoglycemia, and immune system, immune depression. Explanation. MODS involves a cascade of organ failures due to inadequate perfusion. Each organ system can be affected to varying degrees, requiring comprehensive management. Question 10. When should a patient with shock be referred to a specialist? Answer. Refer a patient to a specialist if they do not respond adequately to initial treatment, or if the shock is complicated by severe organ dysfunction, persistent hypotension, or if the underlying cause requires specialized management. Explanation. Specialist referral is necessary for complex cases of shock that require advanced interventions or management of complications, ensuring optimal patient care and outcomes. Overview. Shock is a critical clinical condition characterized by decreased circulating blood volume, which impairs the delivery of oxygen and nutrients to vital organs. This can result in severe organ dysfunction and, if prolonged, lead to irreversible organ failure. Causes include hypovolemia from hemorrhage, vomiting, diarrhea, or intestinal obstruction, cardiogenic causes like myocardial infarction or massive pulmonary embolism, obstructive causes such as pericardial tamponade or tension pneumothorax, and severe sepsis. Symptoms of shock include thirst, feeling faint, palpitations, sweating, restlessness, and clouding of consciousness. Signs include altered sensorium, pallor, cold extremities, collapsed peripheral veins, tachycardia, and hypotension. Investigations include a septic screen for suspected sepsis, chest X-ray, ECG, and echocardiogram for suspected cardiogenic shock, and supportive tests like FBC, BU, creatinine, and LFT to detect derangements. Treatment objectives are to reverse shock, secure airway, breathing, and circulation, prevent complications and multiple organ failure, and avoid death. Non-pharmacological treatment involves raising the foot end of the bed to improve venous return. Pharmacological treatment for hypovolemic shock includes inserting large bore cannulae for rapid 4 infusion, administering colloids or crystalloids like Ringer's lactate or normal saline, monitoring urine output and adjusting fluid rates accordingly, providing oxygen to maintain adequate oxygenation. Multiple organ dysfunction syndrome, MODS, is a serious complication of shock, affecting various organs such as the CNS, heart, lungs, kidneys, gastrointestinal tract, liver, blood, and immune system. Referral criteria involve referring patients to appropriate specialists if symptoms persist or complications arise despite initial treatment. Shock is a clinical state of cellular dysfunction resulting from decreased circulating blood volume, which leads to a reduction in the delivery of oxygen and other nutrients to vital organs. If prolonged, this can lead to irreversible multiple organ failure. Causes: hypovolemia, e.g., hemorrhage, vomiting, diarrhea, acute intestinal obstruction. Cardiogenic, e.g., myocardial infarction, massive pulmonary embolus. Obstructive, e.g., pericardial tamponade, tension pneumothorax. Severe sepsis. Symptoms: thirst, feeling faint, palpitations, sweating, restlessness, clouding of consciousness, confusion. Signs: altered sensorium, pallor, cold extremities, collapsed peripheral veins, tachycardia, pulse 90 bpm, hypotension, systolic BP 90 mmHg. Investigations: septic screen if sepsis is suspected, chest X-ray, CXR, ECG, and echocardiogram if cardiogenic shock is suspected. Supportive tests like FBC, BU, creatinine, and LFT to detect any derangements and correct them. Treatment objectives: to reverse shock, to secure airway, breathing, and circulation, to prevent complications and multiple organ failure, to prevent death. Non-pharmacological treatment: raise the foot end of the bed. Pharmacological treatment: hypovolemic shock. Insert the largest bore cannula, size 14 or 16, in the largest visible vein. 2 cannulae may be inserted at separate sites for rapid 4 infusion. Raise the drip stand or squeeze the bag to increase the infusion rate. Give colloids. In hemorrhagic states, cross-matched blood is preferred, but in the meantime, resuscitate with crystalloids, e.g., normal saline. Ringer's lactate, 4. Adults, 70 ml/kg body weight. Children, see section on management of severe dehydration. Normal saline should be given quickly and slowed only when BP rises and urine flow is adequate. Adults and older children, 0.5 to 1 ml/kg per hour of urine. Smaller children, 1 ml/kg per hour of urine. Catheterize the bladder to monitor urine output. Oxygen, nasally or bifacial masks, 6 L/minute. Continue to monitor BP, pulse, and urine output. Multiple organ dysfunction syndrome. This is a life-threatening complication of shock, affecting different organs moderately or severely, as follows: CNS, encephalopathy. Heart, tachyarrhythmias. Pulmonary, acute respiratory failure, ARDS. Kidney, acute tubular necrosis. Gastrointestinal, ileus, pancreatitis. Liver, ischemic hepatitis. Blood, disseminated intravascular coagulation. Metabolic, hyperglycemia, hypoglycemia. Immune system, immune depression. Referral criteria: refer all patients to the appropriate physician specialist. Thank you for joining us in this detailed overview of shock. If you have any questions or need further clarification, please leave a comment below. Don't forget to like and subscribe for more educational content.